Hello, everyone, and welcome to our webinar titled Cracking the Code, When and How to Validate ICD Algorithms for RWE. This webinar is sponsored by the Partnership for Health Analytic Research, so a huge thank you to them for helping to make this event possible. Joining us today, we're fortunate to have 4 experts from various organizations participating in today's discussion. I'll first introduce Dr. Eric Ben-Shimal, Professor of Pediatrics and Clinical Epidemiology at University of Toronto and a pediatric gastroenterologist and the Northbridge Chair in Inflammatory Bowel Disease at SickKids. Next up, we have Karina Raimundo, Director of Health Economics and Outcomes Research at Genentech, leading the Alzheimer's disease and neuro-rare disease teams. Our third speaker with us today is Dr. Anil Vachani, a pulmonologist and physician scientist at Penn Medicine and the Philadelphia VA Medical Center. And lastly, I want to introduce Dr. Michael Broder, who will be moderating today's discussion. He's president of the Partnership for Health Analytic Research and has over 30 years experience in health economic and outcomes research. And I'd now like to welcome Michael. Hi, Michael. Take it away
Hi.
Whenever you're ready.
Great. Thank you, Sydney. That scared me a little when you said I had 30 years of experience. I didn't realize that I was that old, but I guess I am. But thank you for the introduction. So I just want to talk for a few minutes about my organization and how I got interested in this topic, and then we'll bring on the other panelists and we'll have I hope, an interesting discussion about how and when validating these algorithms is a good idea. So my background is that I was a clinician and an OBGYN in academic practice, and then I left that to work in industry about, now it's 18 years ago. And my thinking in leaving academia was that there really was a place for organizations that brought together clinical and methodologic training to do health economics and outcomes research in an applied setting as opposed to in an academic setting. And my academic career started at UCLA in the RAND Corporation, where the level of methodological rigor is very high, and I thought there would be a use for that in industry as well. And over the last 18 years, we've published a lot of work. The Partnership for Health Analytic Research is only 17 researchers altogether, but we've been pretty productive in terms of our publications. And most of that work involves secondary data or real-world data or routinely collected data in one form or another. So of those publications, you can see that more than half use secondary data analysis in one way or another. And that's mostly commercial insurance claims and Medicare and things like that. And then the other 17% next to that is chart reviews, electronic health record studies, and other sorts of things like that. And so, but my involvement in both of those things made me realize over time that the validation was not a step that was done, it seemed to me, nearly enough. This is just shows you some of the data sources that we commonly use in our studies. The main thing to know about those sources is all but maybe one or two, for example, SEER, none of them really validate any of the information that are contained in coded information in those data sources. So that means it's up to us as researchers to determine when it's important to validate either the outcomes or the exposures or the populations that we're studying. So I just want to share this one more slide. I think that in the FDA recently came out with a draft guidance about using electronic health records and claims to support regulatory decision making. Two things. First is just some definitions. Real world data are data that are routinely collected from a variety of sources in healthcare. And real world evidence is the evidence that's derived from the analysis of those data. So it's not evidence until we analyze it in some way. But the second and more important thing is that the FDA's guidance says pretty clearly that if you want to use real world data to analyze to support a label claim for your product, then what they want to see is complete verification of the study variables. What that means is if you have a drug that's indicated for the treatment of advanced cancer, and you believe that it can be used earlier in earlier stage cancer, and you want to use real world data to support the FDA to allow you to label the product in that way, that ideally what they'd want to see, if you analyzed, for example, Medicare data and you showed good outcomes, longer survival, for example, they would want you to confirm those outcomes in each and every patient that you reported them on. So that's a very high bar. They recognize, but if that's not feasible, then assessing the performance of the operational definition might suffice. And in the FDA's terminology, this operational definition is what we're calling an algorithm. So what they're saying is if you can't verify in every patient that that they had early stage cancer, for example, then you can present evidence that the algorithm that you use to identify early stage cancer it performs well. So one of those two things. So again, that's a high bar, and for most of us doing health economic and outcomes research, we're not required to meet that FDA standard, but it is something worth thinking about as we dive into this discussion. So this is data that I just pulled from PubMed last week. We have a search string that we use to find studies in routinely collected data. And so I used that to create that top green line. So you can see there's been this massive explosion of real world studies over the past 25 years. And then the validation study line I got just by adding some search terms to that search string. So this is the methodology of this is not very strong, but it's about, you can see it's about 1 in 20 that have a validation. And actually, there have been some academic studies on this that support the numbers here. I think we have one of them in the resource section that showed maybe 10 or 12% of published studies using real world data suggested that their measures had been validated. When you dig into that a little bit, though, the actual validation can only be found for about half of those. So under 10% is the answer that I probably would have given. So great, thank you for doing that. Now what I'd like to do is have the rest of the panel join me. Hi, everyone, and thanks for joining me. I appreciate you all being here. This is a subject that I know all of us on this panel are interested in for one reason or another, and I'm excited to have this conversation. And I'm happy that so many of the people who are joining us in the audience have done claims analysis or worked with charts to do studies. And so I think people have a pretty good idea of the problem that we're talking about today. And I hope we're able to offer them some concrete advice about how to improve things. So first, maybe what I'd like to do is just go from person to person and ask you how you tell me, maybe just give me a little bit about your background beyond what Sydney mentioned, and then tell me how the first study that you did that involved validation of an ICD algorithm. And I think I'm going to start in the upper right with Eric.
Thanks, Michael, and it's a pleasure to be here. Very happy to discuss this topic. It's been near and dear to my heart since my PhD, my PhD degree. I'm a pediatric gastroenterologist, a clinician researcher, and my PhD was looking at health administrative data in Ontario, Canada, so population-based universal healthcare system where everybody contained within the data contained within the province is in the database. And as part of my PhD and my fellowship in gastroenterology, I wanted to look at rates of sort of the epidemiology of pediatric onset inflammatory bowel disease, Crohn's and colitis, and look at outcomes. And nobody had done that yet with the large data sets in Ontario. And for pediatrics, nobody had done that with health administrative data worldwide. So it was a great opportunity. And I went to my prospective PhD supervisor and said, well, I want to do this epidemiology and health systems research, but let's go. And she said, well, you really should look at the codes. And in Canada, we use ICD codes for physician billing and hospitalization to make sure that you're actually assessing patients who have IBD. So there needs to be some sort of validation process, because they had found in other conditions like diabetes and asthma that the codes were not accurate. Not surprisingly, physicians are not all that accurate with the way they put diagnosis codes on physician billing, because we just want to be paid. It's not really, accuracy is not an emphasis. So we went about doing a validation study, and without getting too much into the details, we found that your likelihood of truly having IBD, if you had a single code for Crohn's or colitis, was less than 10%. So the positive predictive value was in the range of 7.9%. And so we then developed an algorithm to identify those children with IBD accurately. But it really raised to mind that, like you said, a lot of people are not developing algorithms and validating them. So they're assuming that the codes are accurate. And then we also thought perhaps if they were validating them, maybe the validation studies weren't very well reported. And so we did a systematic review, which was actually part of my comprehensive project in my PhD, to look at how people were reporting and how transparent they were on the validation aspect of things. And I think that's in your resource tabs in the documents. And with that, we developed reporting guidelines for validation studies, and from there led to the record reporting guidelines for all research, observational research using routinely collected health data that have been published about 7 years ago. And we continue, I'm co-chair of the record steering committee with Sinead Langan from the London School of Hygiene. And that really has been our goal over the past 10 years, was to improve the transparency of this type of research. And now we're sort of starting to work on emphasizing the methods, both for validation and for conduct of this research.
Great. Yeah, thank you. That's very interesting to hear. And so you started off with, and when we say ICD algorithm, I think we include things as simple as just using the ICD code for a disease and asking for one or two, instances of those codes. That could be an algorithm, but then you found that wasn't so accurate, and you moved on to something a little more complicated. And Neil, maybe, did you have something else you wanted to add?
No, we treated it like a diagnostic test, right? So where different combinations of codes form the algorithms, and we tested it against a reference standard as we went, the reference standard being chart extraction or a clinical database. And we sort of tested all the different combinations and found one that worked, because that single code really did not work well.
Mm-hmm. Yeah, yes. Anil, I think your experience was a little bit different, but maybe say a little bit about, again, maybe something about your background or how you got interested in this, and then the first study that you did like this.
Sure. Michael, thanks for having me. I'm an adult pulmonologist at the University of Pennsylvania, and our work is largely focused on health services work around cancer screening and cancer treatment. And we got interested in sort of the topic of validation back in, really, it was about 10 years ago. We had just recognized clinically, based on clinical trials, that molecular testing can be performed in patients with cancer, particularly lung cancer at the time, and that the results of genetic testing can then result in being able to choose selected targeted therapies. And we, of course, very quickly, jumped to the fact that these trials were done and that there was an opportunity to answer questions really around uptake and whether there were disparities around molecular testing across the state of Pennsylvania. We were, in fact, able to convince the state that this was a project worth doing, but we hadn't actually thought far enough ahead into how we would actually identify molecular testing in our cohort. And so we embarked on doing case identification using the Pennsylvania Cancer Registry, and had claims from the state through Medicare, as well as one of the large insurers. And we were able to create a very nice cohort of several thousand individuals, with a population-based cohort of several thousand individuals with lung cancer. But we very quickly recognized that there were no specific CPT codes for genetic testing at the time. These were actually very non-specific. There were CPT codes for things like nucleic acid isolation or doing PCR, but they weren't actually codes for specific molecular tests. And so we weren't sure whether these codes would actually find our exposure of interest. And so we embarked then on a several month detour where we actually had to validate these CPT codes to see what their sensitivity and specificity was for our exposure.
Mm-hmm. Mm-hmm. Right. It's interesting. So different. I mean, you were looking at CPT codes and used a registry and not. So exactly. Different experience from Eric's. That's and Karina, do you want to go ahead and?
Yeah, absolutely. Thanks for having me, Michael. In thinking about this panel conversation, I actually was reminded that my very first algorithm validation work was when I was a research assistant in grad school, and I was the one helping collect the data, and it was to validate an algorithm for sarcopenia. So there wasn't a code for it, and I literally called the patients, helped recruit the patients to come in, get tested, and kind of handle the not making the decisions part of the study, but just the execution. But speaking to fast forward in my career, where I was actually leading or help support kind of the planning and the decision on the study, my first algorithm work was to find a way to identify a disease that did not have a specific ICD code. So at the time we were launching one of the products that I was working on for Genentech, and we were expanding our label to include that indication, but there wasn't an ICD code to collect that, to categorize that disease that was chronic spontaneous urticaria. And at the time, and we wanted to better understand the epidemiology, right? The prevalence, incidence, kind of really describe this disease and understand who those patients really were. And the best way to do that was to develop an algorithm. That this was with the assistance of clinical experts in the field. So we interviewed physicians to say, how do you think we should help me develop something like this? And then we went through this second phase, which was this multi-site chart review to make sure that or to check which algorithm was performing best and making tweaks so that we would have something that actually worked, had good sensitivity, and it was good for us. It helped us identify patients moving forward. This was in the ICD-9 times still, and there is a code for the ICD-10 once the ICD-10 transition happened, but it was helpful to have a code or a set of codes and algorithm to help us truly have confidence that we had the right patients.
Yeah, I think that's interesting. Thank you. And I'll just share my experience, which is about maybe 10 or 12 years ago. We were doing a study involving a rare form of pediatric epilepsy, and we decided that we needed to validate whether our algorithm, which had been used and published in a study, whether the algorithm that we were using really identified the patients of interest. And I started just by talking to a few pediatric neurologists, and they pulled their records. And actually what I found was that the 3 neurologists that I spoke to, each one had a slightly different way of coding these patients, and none of them were the same. And so we called it off at that point. We decided that it really wasn't going to be feasible if that's how different things were, that we didn't really need to do any more validation than that in that study. And it was years later that I did actually the first study where we actually pulled the medical records and validated the algorithms. But that first experience was really what got me interested in this whole topic, because I realized that, had we not done that, I would have gone ahead with this research thinking, oh, somebody else used this algorithm. It was pretty straightforward. It asked for 2 codes and 2 tests, and those should be done in every patient with this diagnosis. And so that seemed like a, conceptually reasonable way to do it. But in the real world, it turned out that wasn't actually very good at identifying the cases that we were interested in. So I think So my experience then, the first one was was actually kind of an informal validation. But thinking about the validation studies that you've published, maybe you can share about the reference group that you use. So Anil, yours was in a registry, is that right? That's how you used that was the gold standard, and that registry already existed. You didn't have to create that.
Yeah, we used the Pennsylvania Cancer Registry to identify our lung cancer cases, so we were pretty confident based on sort of existing processes that our population was correct. But to validate the actual molecular testing, we sort of use standard brute sort of force chart review. So we had an EMR at the time which facilitated the process, but we essentially, for any person that we thought had molecular testing based on an existing CPT code, we would scour the medical record to see if we could actually find testing for, at the time we were looking for EGFR mutations and KRAS mutations, which was the standard at the time, and really just pulling out individual test results to see if those were present. And ultimately, our inferences that we wanted to make were whether those test results were informing therapeutic decision making and whether that varied by race. And so we felt like there was really no path forward without having to actually go to the charts and confirm that finding, given the uncertainty around the CPT codes.
Yeah, charts, and Karina, that was the way that you first did your when you talked about the actual validation, going to medical records and pulling those results to confirm. Is that right? Yeah.
Exactly. But I want to say, I think the sarcopenia example that very early on in my career was kind of interesting because they, at the time, and what we were doing was in fact diagnosing patients with sarcopenia in the process to validate. So we were not relying on a physician assessment or like pre-diagnosis of sarcopenia in that case. We actually got patients to come in, get a DEXA test scan, and some kind of physical activities, kind of like strength tests as well. So we actually were, diagnosing patients, if you will, right, with sarcopenia, and then validating the algorithm, which was kind of an interesting and bold approach.
Yeah, that is interesting. And we're kind of all the what we're mostly talking about is using as a reference standard the medical record. But the point that you're kind of alluding to here is that medical record is not 100% correct. So even our validation work, we're really not validating, generally speaking, we're validating against some retrospective thing that's been identified in a medical record. And we're assuming that that's correct. But your approach, that what I might call the kind of a research standard, is you're really validating the actual diagnosis. And if you do that, I suspect there's even greater error than just looking into the medical record alone, because you're catching people who were not diagnosed.
And I think it depends on the type of disease too, right? So if we're talking about cancer, I don't think I need to go in there and diagnose patients with cancer. They're probably going to be in the system and have accurate diagnosis there. If there are other conditions that are poorly diagnosed, or physicians don't have the incentive to arrive to the right diagnosis because the class is enough, that might be why that becomes a problem.
Mm-hmm. Yeah, different diseases and conditions require different approaches. And so, but all of these methods are kind of labor intensive and difficult. But I'm wondering if any of you have experience with using approaches like machine learning or other sorts of computational methods to validation. And maybe Eric, I'll ask you that.
So I don't really. We've developed algorithms to identify like disease severity in patients with inflammatory bowel disease using machine learning algorithms, but it's always been with a reference standard of, the chart review or having the clinical truth in some form or fashion. I've certainly, as part of that reporting guidelines, we did a systematic review of the literature of all the validation studies back in 2010. So obviously things have evolved since then. And there were a few studies that used Bayesian analyses to define a probability of having the disease based on the administrative data itself. There were also studies that validated one source of administrative data or routinely collected health data against another source of routinely collected health data. And if I think, again, like you said, that if you know that one of those sources is the truth and is the true reference standard, that can work. But I think in the end, you really do need a good reference standard in order to know that your validation is effective.
Yeah, I think that's right. I mean, I think that's a good point. You know, without that reference standard, there really is no effective way to do any of this. And sometimes that's a medical record. In other cases, depending on what you're doing, there might be a registry that can be used, or patient report. Depends on the outcome of interest. But there
And
has to be
I'll
that
tell you one example of where things went wrong for us, for me, right at the very beginning. And I think I realized fairly early that it was not right. Was we used in our pediatric Crohn's and colitis algorithm, we used a disease registry, a database of all the patients seen with Crohn's and colitis at the Hospital for Sick Children, Sick Kids in Toronto, the only pediatric hospital in Toronto. So we assumed everybody not seen who was living in Toronto at the time, not seen with Crohn's and colitis at Sick Kids, likely did not have IBD, right? That was sort of the assumption, and that was a reference negative standard. And the advantage of that method was that we were able to get a validation cohort, true positives and true negatives, that mimic the prevalence of the disease in the actual population, because we assumed everybody true positive would be in the database and everybody true negative would be in the administrative data, everybody living in the city. What we didn't anticipate, and what I saw very early, was that the algorithm functioned very differently in children under 16 compared to children under 14 compared to children under 12. The positive predictive value increased significantly, even though the prevalence of the disease went down. And we'll talk about positive predictive value, I think, in a second. But that was telling us likely is that some of those true negative patients were being classified as positive, even when they had many, many codes for IBD. And I think what was happening there was they weren't true negatives, right? They were sort of older teenagers, mid-aged teenagers who were being seen by adult gastroenterologists because they were more mild, or they, didn't have access to a pediatric center or whatever it was. And so they were being treated out there, and our database was not complete. And then all of a sudden, you've got a reference standard data set that isn't complete, that messes up your estimates for the algorithm. Luckily, we had plans to validate it in other centers and in private practices and community hospitals and that sort of thing. So we had a backup plan of what we would do, but that was sort of eye-opening that you can't make assumptions. You really need to make sure your reference standard is good.
Yeah. And Karina, did you have some experience with using machine learning or some other type of algorithm? I mean, some other method for developing an algorithm that you?
Yes, I have, and I'm looking at the question here, right? In using machine learning to have big data tell you how to define your algorithm and just find a predictive model and going with that. And I think at face value, it's a great idea. The challenges are that you end up with something that ends up being very complicated. So other researchers may or may not adopt that algorithm. I think I've seen a lot of pushback from the clinical communities or physicians when you come up with something like this, and they say, that's not how my patient's going to show up in my charts. The other issue is it depends on, to Eric's point, it depends on how representative your data set really is. And the issue that I was faced with was that I validated in one health system and I had no external validity. So when I tried to use that same algorithm somewhere else, the patient population just looked wrong, and that's not very scientific, right? So I didn't necessarily try to validate in another system. I didn't have the resources to do that at the time, but just looking at the patient characteristics and their comorbidities, etc., it was clear that we were not identifying the same population or the right population. So I understand why people want to try machine learning to develop algorithms, but I do think we need the clinical expertise to help us guide how we come up with the actual algorithm so that it will have, or in my experience, I've seen that has more external validity.
Mm-hmm. Yeah, no, that's interesting, and that makes sense. And I think I spoke to somebody at the FDA in the Sentinel program before this webinar, and they've posted some things, and I have some information about their attempts to use kind of these big data approaches, and they're really just scratching the surface of it. I think that it seems appealing to all of us who've worked in this area because it's so difficult to do this kind of work that we'd like to be able to see, harnessing this great computational power to do this. But I think my experience has been similar to yours, Karina, that it's hard to get anything that has face validity. And then I think that, confirming it in other data sources is really important, and that you're not overfitting your model. So maybe, since we're talking about some difficulties, maybe I think it's a good time for me to do my next quick poll here. And what I wanted to ask people about who are here are, what do you think algorithm validation is done so infrequently? We've all talked about some difficulties that we've had, but maybe if you can just if the audience can respond to this. The answers are pretty equally split among all of the responses. Too much time required is the most at 37%, and then researchers don't know how important, and too costly each get about 25%, and journals don't care is another 15%. So a lot of different answers. I think that I'll bring it back to the panel. Why? Anybody want to answer why you don't do this more?
Yeah, Michael, I might just make one comment on the journals don't care part of this, which is that it's sort of a catch-22, right? And I have the opportunity to work as an associate editor for a pulmonary journal, and it's true. I think that journals would not view a validation manuscript as sort of high enough impact to want to publish on its own. But we care enough that we want to, of course, be publishing work that is valid, and so it is a bit of a catch-22 that we look at these manuscripts that are using code-based algorithms to measure exposure or outcome or a related variable, and we want to see just enough validation. Ideally, of course, we'd like to see that the validation's already been done somewhere else in the past, and we can just move forward and worry about the analysis at hand. But if a code that's being used isn't validated, it does give me pause as a reviewer or as an editor to say, is this real, or is this just completely unvalidated and therefore not worth publishing? So I think that there is this fine line that I think authors and researchers are going to have to walk going forward, that I think we will care more about this, and we have to figure out how to get it into our workflow in a more robust fashion.
Yeah, I should mention, Anil, I agree. I think I'm also editor of a few journals. It's hard for clinical journals to care that much. I think they want the validation done, although they need to know to look, which was one of the reasons for the reporting guidelines, the record reporting guidelines, is that it actually demands that you report whether or not the validation was done and where it might be published. There are journals that emphasize validation studies. So I'm editor at Clinical Epidemiology, which is an open access journal, which actually had a call for validation studies a few years ago, because I think they recognize they're a journal that really does emphasize administrative data research, and they recognize the importance of those validation studies. In addition, I think it's worth journal editors knowing that those validation studies end up getting cited many, many, many times, right? Because people are relying on that to do their research in the future. So I'm hoping that is changing. There are homes for those types of studies. I think certainly for me, it's a matter of cost. Unfortunately, validation studies are not sexy. They don't change the world in terms of clinical care or health systems or health policy. So it's difficult to get them funded on their own by granting agencies. And, so I try to work in a validation study with almost every grant that I submit, in order to be able to do a little bit more each time. They're also, they're expensive, they're time consuming. I think if you had unlimited money, you could hire unlimited people to do the validation, but it's difficult to get that funding.
Yeah. I found something pretty similar. We work in an industry where our pharmaceutical or biotech company clients, they want to do the research that they approach us to do. What's the epidemiology of this disease? What's the burden of this disease? And if you say, well, before we do that, we have to do this other study, it's going to delay us, 6 to 8 months or even longer, then that becomes a problem. I do think it's worth, what I've done several times is do kind of a very, poor man's validation, which is just to get some clinicians to look at their own billing codes and just say, do you see these codes? Is this what you see? And it's not much, and you can't really point to it, and I wouldn't want to argue that that's the best way to do it, but at least it has given me a little more confidence that we're on the right track. I mean, that's in cases where I'm talking about things where you have a rare disease where there isn't a specific code for it. I think, really the best approach in those cases, obviously, is you have to validate it. And before you could do anything, like I mentioned at the beginning, go to the FDA, you have to have some validation. But sometimes we're at the beginning of investigating a particular disease, and the best you can do is just say, well, here's a combination of codes, and we think this has some base validity, and here's the study that we did. Let me ask.
I think it's all about,
yeah, sorry.
I think it's all about incentives, to your point, right? So I think we're all saying here it's not the most interesting study that we're going to publish. It's going to take time. It's costly, and right, like primary data collection. So it's unpredictable too, right? So maybe you say it's going to take me a year to do this, and then something happened with the sites, with the chart abstractors, and it delays. Kind of, in my experience, every time you do it, there are delays. So what is the incentive? Is it because I want to make sure that I trust the data that I am putting out there? If that's the incentive, then maybe I just check with a few physicians. Is this right? Is this how you would approach this? It doesn't have to be that rigorous. I think now with the FDA signaling to us as a community that, or as researchers, that they would like to see more validation work being done for things that are submitted to them. Perhaps that's going to be the incentive. Perhaps ISPOR has a role too in helping us kind of move the field towards more rigor. But I think until we have a reason to validate that's beyond just we want to make sure that this is well done, we're not going to see more work being done.
I should say that ISPE actually recently funded and the membership has endorsed a paper guiding people on how to validate. So almost like a methodologic sort of textbook chapter on validation studies. Vera Ehrenstein from Aarhus in Denmark led that. And that should hopefully be published later this year. It's just under review with a revision. So I think that at least ISPE, and ISPOR is also very involved with this field, but I think that they have emphasized how important it is with that type of paper, and we've produced a guidance document that'll help with that. So now it's just a matter of finding people willing to actually follow the guidance.
Yeah, no, I think what I'm trying to do my part by when I'm asked to review things to make sure that people mention their validation, and if they haven't done validation, to mention it. And the other thing I try to do is not let people get off with a limitation that just says, miscoding may occur. Like I know that we tried to do something. It's very complicated to actually try to estimate the amount of error in a real world data study. If you don't have validation statistics, but at least to be able to say, here's the range of, possibilities of how far off we could be in our population identification or the outcome assessment. Something like that is a little bit better than saying, misclassification or miscoding may occur. So I tried to do that. Well, we're almost at a quarter of the hour, and I do want to leave some time to answer some of these questions that I see coming in. There are some interesting questions here. So, and some very practical things. So maybe let me ask this one. Let me read this one. So, what do you do if your validation study reveals poor performance? So you've gone to all this trouble to do this, and I guess embedded in this is maybe what is poor performance. Eric, go ahead.
Yeah, so I mean, I've encountered that where my validation study fails. It happened to me for celiac disease. It's happened to colleagues of mine for autism. Not surprising, it just didn't work. I think two things, and there's a link question there: is what is good enough for sensitivity? Yeah. So how do you tell if it's failed? So firstly, I think for good enough, I think we need to get away from that idea. Because I think, it depends what research question you're trying to answer. So, what characteristic, whether it's sensitivity or specificity or predictive values, which is more important will depend on what your question is and what your research design is. In some cases, you may be okay with a sensitivity of 60% if you know that your positive predictive value and your specificity is very, very high, because you want a true sample of patients and not false positives. On the other hand, in other cases, you may want to catch everyone in the population and you need a high sensitivity, but you're okay with some false positives. So it really depends on what kind of cohort you want to design the study. And so I don't think that we should be using cutoffs. And what if it reveals poor performance? So for us, from record, this was maybe one of the most frustrating parts of learning to develop a reporting guideline, is all we could say is transparency, right? Like we could only encourage reporting and transparency. We can't encourage doing or making it good. So in the reporting guideline, what we said was that you must report whether or not the codes you've used to identify your cohort, to identify outcomes, confounders, effect modifiers, were they validated? If so, provide a reference or give us information about the validation study. If not, tell us that they weren't validated. So at least you're transparent that they haven't been validated. So I would encourage that if it reveals poor performance, you have to be transparent about it, and you need to be aware of the limitations of your study. But in general, honestly, if it's a poorly performing algorithm, you probably shouldn't be using it for research, because everything that follows from that is not going to be reliable.
Yeah, that's I think an informative answer. And I just echo something you said about I think people always want to know what's the cutoff or what statistic should I use or that kind of thing. And I think, unfortunately, the answer that you gave is really the best one, which is that it depends. And it depends on what your goal is. And I also think that it's useful for people to understand how in a sense, poorly many of these ICD codes perform in general. And that just by reporting it, by saying, look, our sensitivity is 65%, and we know that, then even though that might not be what you want, at least that number gets put out there. And the more times people see those numbers, the more they recognize that this is just what it is. This is all of the research that we're doing using these routinely collected data. When we don't validate, then what we're getting are numbers like this. And so I think by putting those numbers out there, you're not only helping yourself because you're following the record guidelines, which I think is important, but also you're helping the community of future researchers make the case for why these studies are so important, and why that, when we find something that is 70%, that we can say, oh, that's good, that's better than many of these things. Karina or Neil, anything you want to add to that?
Yeah, I think just to sort of more explicitly state. No, I'll go quickly, which is that I think that if your algorithm is performing modestly, and it's just very important to understand, if you're going to go forward, what the direction of the bias is, or as already sort of stated, and is there a role for a sensitivity analysis that might allow us to understand how far off your conclusions might be, if that is appropriate to be robust about using those sort of two approaches. So.
Mm-hmm. Yeah.
In another suggestion, I guess, is not to be, at least in my experience, developing algorithms and validating them. I approach this a little open-minded, I guess. So I test a few different variations of the algorithm, mm-hmm. right? So I am not going with that's the one truth that I think is that I want to see how it performs. But how would those three different algorithms or four would perform with slight variations if I include prescription drugs, if I don't include that, if I include hospitalization visits, whatever it is that it makes clinical sense in that space. But I would test a few algorithms and then you just report how they all perform. And there's probably one that performed better than others, even if not great. So that alone gives a direction, gives you an idea of the direction that you should be going for the future. So I would say maybe not go with just one.
Yeah,
fix that word.
I think that's a good point. And I think, Eric, you said something like that at the beginning about how you approached your validation
So
study.
if you look at the supplemental data on the papers of the algorithms that I validated, there are thousands, right? So it's pretty easy to test, with programming, to test thousands of different combinations. I think it's worth mentioning what I sort of looked out for as the best markers of validity, because the disease that I'm most interested in children is pretty rare, Crohn's and colitis, compared to adults anyway, where it's about 1% of the population. And so because it's a rare disease, achieving a good positive predictive value is very, very difficult. So what I defined ahead, and that's another good point, is like try to define ahead of time what you consider an adequate algorithm. And I defined that I wanted to maximize positive predictive value while maintaining sensitivity above about 80 or 85%. And so we tested thousands of different combinations of hospitalizations, physician billing, procedure codes, and we came up with one that did that. The reason positive predictive value is so important is because it really, in a rare disease, your specificity and your negative predictive value will approach 100%. So it's really that number that will tell you how many false positives are washing into your cohort, potentially diluting your sample. And so we try to maintain a good positive predictive value. And that, another important point with validating predictive values, and most people don't do this, is that if you're going to report predictive values of your algorithm, you have to make sure that the prevalence of the disease in your validation cohort is approximately the same as the prevalence of the disease in the population. Otherwise, let's say you don't have a full true negative population and your prevalence is 9 true positives for every 1 false positive, that's 90% prevalence. Your positive predictive value is going to look amazing just because your prevalence is so high. But then you apply that algorithm to a population database where the prevalence of the disease is 1 in 10,000, and all of a sudden you don't know what your predictive values are doing, but they're probably much, much lower. You just haven't got a clue how they're functioning. So that's an important point about the reference standard, is make sure that that prevalence is about equal to what it is in the general population.
Yeah, I think those are both good points. I mean, validate more than one thing if you can, or attempt to measure more than one thing. That's a good way to avoid, a kind of a real failure.
Yeah, and to Anil's point about subgroups, sub-validation, that's another thing that we realized is age is an important factor, right? Patients are not treated the same if they're 12 compared to if they're 45. And so the validation may depend on the age group of what you're looking at. Jurisdiction, so Kaiser, where it's salaried physicians, the frequency of visits, the billing may not be the same as a fee-for-service model. And, other subgroups like male, female, gender differences, and so on. It's disease severity differences. It's important to validate those subgroups.
Yeah. And I think another good point that I think it's good that we talk about, we have a few minutes left, is this idea of which statistics. And I know people are always interested in that. And Eric, you commented on this. If you look at the reported validation studies, positive predictive value is probably the most commonly reported value. And that's because, it's once you have your algorithm, if you pull those cases, if you pull the medical records of those people that have positive tests, that you can calculate that statistic. But as you point out, it's not necessarily the most useful unless you're doing it in the right population. So, people, and another question sort of came up about how is there any way other than choosing a sample of patients that matches the population that you could produce some of the other important statistics, the sensitivity and specificity? I mean, is there a simpler way, or is there something that requires less time or energy? People want to know if there's something that they can do to get a validation sample without all that work. I think my answer is going to be no.
I'm not aware. I'm going to say I'm not aware.
I think that yes, I think it really is just I think it's a process that begins by thinking about what do you want this algorithm to be best at. that it can't be perfect at everything. And if you want it to be best at identifying and not missing any cases, then you have to go into it with that mindset and choose a sample purposely that does that. If you want to make sure that you don't inadvertently identify that you don't have false positives, you have to choose a sample that is going to test your algorithm's, false positivity. We've also we've got a question here about how is the panel's in the panel's experience, how does the algorithm vary by source of real world data, claims versus EMR versus registry? So that's an interesting question. I mean, I guess I would have to say my experience has really only been in developing algorithms that use things that we see in claims and not any additional, that's mostly what I've been doing. But have the others of you used other data sources? And you want to comment on that?
So we're starting to, I think the reality is the future of all of this is linking clinical data to the claims data, linking, more detailed, even free text data to administrative data, both because it gives you a level of clinical, detail on the patients that you wouldn't otherwise have, but also because I think you're probably going to be more accurate. And so with time, you can imagine times where free text, machine learning, will be the future of identifying patients. We're not quite there yet, but I think the more data you have to validate, the better it is. But then it may not be as applicable to other places, right? Like if you have linked EHR data to admin data in your jurisdiction, not everybody will have that, and therefore it may not be as usable for other people.
Mm-hmm. Mm-hmm. Yeah. And Neil, have you?
We're doing a little bit of work to look at this EHR versus claims question, which is that, it's certainly true that events can appear to occur in EHR data where a physician may click, an event, a code, a disease diagnosis. So it shows up in EHR data. Whether it's a real diagnosis or not can sometimes be gleaned through notes and progress notes. And that's hard work. We're starting to look at a little bit of that in one of our studies, but it's very early, it's very hard, it's very time-consuming work to do. I think that NLP tools may help in studies like that, but I think that's still an evolution.
Yeah. I think, so two questions came in that were related. One, is there a way to validate ICD algorithms when we have only claims? And then why not use a combination of other factors to validate the claims algorithm? And both of these, I think, allude to something that I would think of as an internal validity check, which is maybe not a validation study per se. And my opinion is that that's a useful thing to do. And I think that it certainly can be done in almost any time we do a study using these routinely collected data, which is to say, when I use this algorithm, do I get a group of patients that looks like the patients that I would find in a clinical trial or someplace where we know they have the condition? So my response would be, yes, that's useful. And I think if you want to describe that in a manuscript, I wouldn't necessarily describe it as a validation study, but maybe, I don't know, something, again, maybe it's face validity that we're really talking about there. But any comments on that?
Well, I think it's, you can look at...
Yeah, Corinna, go ahead, and then Eric. Go ahead. No, Corinna, you go ahead.
Okay. I had just said the lives we live in right now, right? With the internet connections and all. I think this always should be done, regardless. So I agree that that's not a validation per se, right? It's not a validation study of either the identification of the population or the outcome algorithm. But we should check that and report how our population looks like, and are we finding the patients with the comorbidities that we know that they should have, and kind of the makeup, age distribution, or those things we should always check for.
Yeah, Good, great, thank you. Eric, did you have something to add, or was that?
No, just very quickly. I mean, you can always validate one administrative database compared to another. For example, diabetes, you could validate patients and use frequency of hemoglobin A1C testing to say that they had diabetes. But I think you have to acknowledge that you're not 100% sure that either one of those is truth, right? So there's limitations to that as well.
Well, great. Thank you. I mean, I think we're going to have to wrap it up for time, but really, this has been a really great discussion. I've certainly enjoyed talking to you. I hope for the audience that it's been useful. And there will be a recording available, and Sydney will come on in a moment and explain and a poll that she'd like you to do, and she'll come on and ask you those things. But I just want to say, on behalf of myself and the other panelists, thank you for attending this webinar, and I hope you found it useful. Sydney.
Thanks, Michael.
Yeah, thanks everyone for joining. Thank you, guys.